Welcome to the Gerontological Society of America's Momentum Discussion podcast, where we explore the groundbreaking topics and advancements that are generating significant excitement in the field of aging.
Welcome to this GSA Momentum Discussion podcast episode titled Journey to Guide, One Practice's Road to Implementation. Momentum discussions highlight topics experiencing great momentum in the field of gerontology. We're grateful to AZI, Genentech, Lilly, and Otska for their support of the GSA Care Toolkit for Brain Health and today's podcast episode. My name is Jen Pettis. I'm the Director of Strategic Alliances at the Gerontological Society of America, or GSA, and I'm recording this podcast episode live in the podcast booth at GSA 2024 in Seattle, Washington. This year brought the implementation of the Guiding an Improved Dementia Experience, or GUIDE model, a Medicare payment and service delivery model. During this podcast, we'll learn about that model and how one practice has made their journey to being a GUIDE provider. My guests for today's podcast are my friends and colleagues, Dr. Carolyn K. Clevenger, a professor at the Nell Hodgson Woodruff School of Nursing at Emory University, and the founder and director and a practicing nurse practitioner at Emory Integrated Memory Care, a nurse-led primary care practice for people living with dementia. Dr. Clevenger is joined by her colleague, Laura Metters, a licensed clinical social worker and the administrative director of Emory Integrated Memory Care. Welcome, Laura and Dr. Clevenger. I'm so glad you could join me.
Thank you so much for having us.
It's always a pleasure, Jen.
Thanks so much. Laura, to start with, could you tell our listeners about GUIDE and the services that the program will provide people with dementia and their care partners?
Sure. So GUIDE, or Guiding an Improved Dementia Experience, is an alternate payment model through CMMI, or the Centers for Medicare and Medicaid Innovations. And they wanted to offer a different way to pay for comprehensive dementia care. And so they looked at what are other programs doing across the country who are already providing these services to patients and families, what types of elements are really featured and highlighted and necessary if you're providing really good comprehensive dementia care services. So they looked at several programs throughout the country and came up with certain elements that they noticed were pretty consistent with really good dementia care and put that into this new alternate payment model for people who are receiving traditional Medicare benefits. And so part of the elements are making sure that people have a diagnosis. So they are getting those cognitive assessments, they're getting that diagnosis, and they are getting some idea of what stage that their person may be living with in the disease process. So we know that sometimes that's really difficult to do. It's really important that people have an idea of where they are in their journey. And so that is a critical piece for providing really excellent dementia care, is really doing that, those assessments, and making sure that the patients and families have heard that as well. Care coordination and care planning is also a critical piece of really providing good dementia care. So you can't just give the diagnosis and say, okay, bye. Families need a lot more support and hand-holding when they get this diagnosis. So you need to be able to connect them to community resources. You need to be able to connect them with a plan for how they're going to address the symptoms that their person may be experiencing and living with. And you also have to provide access to 24/7 care through a care team. And that, I think, has been very important, particularly in our practice for our patients and families. We've had some people say, I've never had to use your 24-hour, it's an after-hours line, it's not a 24/7 line, but I've never had to use your after-hours line, but just knowing that this is available has given me so much comfort and confidence that I'm in the right place. So they feel like you have a team that is supporting them and will be there when they have an emergency. So providing that caregiver support and education is also really important. We really believe at Integrated Memory Care that our caregivers are our best intervention for our patients who are living with this disease. And having a really well-educated care partner really impacts the trajectory of the person who's living with dementia and the experience that they're going to have. So if you can provide that education and provide that support for families so they are not scared or frightened or making really rash decisions when a new symptom comes up, it, I think, helps everybody remain calm when they're in the middle of this crisis. If a family member does not know that it is normal for their person living with dementia to forget who they are, it can be so alarming. It obviously is an emergency. Obviously, this has never happened before. How could you not know who your spouse was? How could you not know who your daughter was? And we're all like, what did you expect? This is a normal part of the disease. But if you have not been told the diagnosis, do not know that this is a normal symptom, it is very alarming. So again, providing that caregiver education and support is really important. And then for the first time ever, Medicare has acknowledged that caregivers sometimes need a break. And so for eligible care partners or patients, care partners will get a $2,500 respite to use towards services in-home care, potentially an adult day program, or potentially just respite care at a congregate living setting as well. So that is really cool and unique to the GUIDE program.
Terrific. I want to ask just a couple of follow-up questions. Is GUIDE available for all different people with all different diagnoses of dementia? Is it?
Yes.
So any type of dementia due to any cause. That's terrific. And then how many sites are there, Laura?
It is a program that people had to apply to participate in. So health systems, clinics, different health providers or services had to apply with CMMI and say, this is something we are interested in doing. And they could apply and either be an existing site, which started in 2024, or they applied and will be a new site, and it will start in July of 2025. There are approximately 75 existing sites throughout the country right now, and then we expect that there will be about 390 GUIDE sites when the new sites become live next July.
Great. And Dr. Clevenger, on what care models did CMMI base its required services that Laura just reviewed for us for the GUIDE model?
So like Laura said, when Medicare CMMI, specifically the Innovation Center, was looking to create this alternate way of being paid and delivering care, it's based on best practices that are out there. And so there are these comprehensive dementia care practices across the U.S., and many of them were funded as they started by the Innovation Center. And I would say in no comprehensive dementia care practice that I've spoken to created their model to keep it local. Everyone created this model because they wanted to either replicate what they're doing by supporting other sites to do that or by modeling best practices and publishing and disseminating. When Medicare is looking to create like this nationwide program, they're basing it on published outcomes. These are evidence-based practices, meaning the practice, that they're seeing in the literature. And they had, of course, an investment in these practices starting with a long-term eye toward if we can test, and that's the Innovation Center, right? We develop innovative practices or practice models, we test them, we look at outcomes. If they're effective, we talk about scale. And this is the scale sort of phase of that. Now, 6 of the practices joined together and were identified in a report by the Milken Institute titled Scaling Comprehensive Dementia Care. And there's an appendix there, and you can see a side-by-side table of 6 comprehensive dementia care practices. Now, none of us are the same. We all do different. The models are different at every site, but we agreed on these common elements. And at the risk of forgetting one of the sites, but I don't think that I will at this point. So we've got the Benjamin Rose Institute and their care consultation. We've got Care Ecosystem. We've got Mind at Home. We have the Aging Brain Care Med Home. We've got the UCLA D-Care program. And then, of course, Integrated Memory Care. And that chart, I think, has been helpful. There's a side-by-side comparison for people who are interested to see how they're staffed, what the services are that they deliver, what their outcomes have been in terms of what they've published on both patient outcomes, caregiver outcomes, and cost, and then also an idea of what the investment is to create a model like that. And you could imagine a very high-touch model like ours, which we have a lot of contact with our patients. We have really robust outcomes, but we also have, a robust investment, mostly in the team, which we love our team, so happy to make that investment. And I think each of us feel like it's the right model for our health system. And there's a recognition that the model that each of us have might be different and ideal for different systems, different communities, different cultures, and so forth. Those 6 are published in a couple of different places, but all of us are interested in some degree of sort of contact. That may be telephone, it may be online, it may be a consultation one time, and then we're the extreme end of that, which is we begin with people and we stay with them until it's time for hospice.
And I understand that the 6 of these evidence-based models have come together to form the National Dementia Care Collaborative. Tell me about the collaborative and how its members can support other organizations seeking to become guide sites.
Because each of us in these 6 comprehensive dementia care models developed and tested this, and many of us, not all, come from academic centers as well. We published, we are pretty open about what we deliver. You can find it in peer-reviewed literature, you can find it in podcasts and webinars, right? We want other people to take up our best models, our best practices. So we've formed this collaborative, the National Dementia Care Collaborative, or NDCC, with the generous support of the John A. Hartford Foundation, so that some of the practices, some of our models have already been replicating their model in other health systems across the country. And some have done it many, more than 10, more than 20, some have had just a few. And not everyone has that infrastructure created for it. If you look up integrated memory care, you will find information about our practice itself that's patient-facing. You will find our outcomes and things that we've tested and developed. If you look at the academic or the published literature, you would not necessarily realize that there is a pathway to replicate an IMC type of practice at your system with our support. So there's that infrastructure that we started to pull together. The collaborative has worked pretty closely with the Innovation Center, the CMMI team, and we have offered one summit last year when Guide was initially coming out. There's another summit actually in this month, in 2024. They've created a web presence so that for practices or systems who are either interested because they are standing up a new guide site in July of 2025, and it would be helpful to learn lessons from those of us who are already an established guide practice, and to implement a model rather than coming up with something on your own in your health system, to look at an evidence-based model that has been tested. It's not even just a matter of we have our workflows, I have position descriptions, we have note templates, we have billing guides, all of the lessons we have learned through some pain points of our own, maybe don't go through those pain points. So there's that sort of just logistic and practicality of following an established model. But there's also the fact that we have demonstrated outcomes, and they're the same outcomes that your guide site will be measured against once you are live. We've been successful in avoiding hospitalizations. We've been successful in deprescribing, especially high-risk drugs. We've been successful in reducing caregiver distress and burden. We've not measured quality of life. That will be a new one, and that's a tough one to measure. And I think everyone's clear that with Guide, the measurement tool that we'll use is a little bit probably not designed for the purpose, that what we're using it for now. But so we, based on our outcomes, and I would say the other 5 models as well, we would expect we will be quite successful in meeting the goals and the outcomes that the Innovation Center is holding us to, and that has implications for the success of Guide overall. It has implications for the amount, your payment amount, because this is a payment that is adjusted based on outcomes after the first few years. So the idea of the collaborative is to say to practices, especially if they're standing up Guide, but honestly, if any system or practice locally is saying, we have this population of people living with dementia. We know we could do a better job supporting them. We know we could offer more comprehensive services, and they want to move forward to do that. We also want to support them to do that, whether they're in Guide or not. So to create this more centralized resource where people can go to one place, they can learn about these 6 models. They have a contact for who they might talk to learn more. They get an idea of how this fits at their system or not. And in the next year, we will begin to have affinity groups so that another practice who are interested, if they want to adopt the IMC version, if they want to adopt the Benjamin Rose Institute's practice, they can listen to those and learn lessons in that way. And each of us have different sorts of way to support those practices. But that's the idea behind the collaborative, is that it's one more centralized place versus each of our models independently trying to let folks know, hey, we're here to help you, we're here to support you, and we just want to see better dementia care for everyone.
Excellent. I want to spend the rest of our time together talking about your team's journey, so the Emory Integrated Memory Care's journey to becoming a guide site. I know you're going to publish some of that journey in a poster here at GSA 2024. And I also know you started enrolling in July, right? You enrolled your first patient in July. So I'd love to learn about your experiences since you started enrolling your patients. Who wants to get us started?
I'll jump in first, and I'm sure, Laura, there's been so many things about this, right? And so you would think IMC, just a level set. So integrated memory care means the integration of primary care and dementia care. and caregiver services all under one practice. And so you would think this is already a very comprehensive dementia care model. Clearly, we were involved in these conversations back in the days of that initial report about scaling comprehensive dementia care. We created that sort of label or term for what our practice is, ours and the other fives, what that means, what the core elements are. And we've known about GUIDE before it was called GUIDE. We had a sense that it was coming. We should be the most prepared. There are still a lot of process and workflows and adjustments that we've had to make, and I'm glad to do it, but it's a journey. It's aptly named. So I would say of those 3 columns, that's how I think about our practice when I'm introducing it to patients and families, that these 3 different services happen under one practice. So we shared in poster today, and I'll walk you through how we made those adjustments. So from the primary care side, I would say that's maybe the least adjustment that we've needed to make, because we are still doing that chronic illness management. We're still dealing with acute respiratory illnesses in the season that we find ourselves in now. We are still looking at that bladder medicine and how it's affecting your sleep and how it's affecting your cognition and all of those sorts of things, because as I like to say, your brain is connected to the rest of your body. So the fact that we're doing your primary care, but in the context of dementia, maybe is the least of an adjustment, but there's still adjustments there. What we put under primary care are things like annual wellness visits. Annual wellness visits are included under GUIDE. That's included in your dementia care monthly payment. And so we are still doing the annual wellness visits, but we had to tweak then the billing because that's a disallowed code now. And you never want in any of these changes of codes to, of course, rely on like everyone in the practice just remembering, oh, this person's a GUIDE patient. So there's some automation. There's been a lot of ongoing counseling and support is what I started to say with the IT team. There's the billing team, the coders, there's the finance team, and then there's the actual medical record folks. So there's a lot of sort of that. So automating those sorts of things. And the same thing is true for the care management, care coordination. So we are doing care coordination for all kinds of reasons. Yes, dementia, but lots of other things too. And so we've been doing chronic care management, complex care management, principal care management, transitional care management since those codes went live with Medicare. That was the year that we opened in 2015. So we still are doing those activities, but the way we capture them, and then of course it's another disallowed billing code. So we've got to just make sure we don't bill for that if we're already doing that. And then we think about deprescribing under the umbrella of primary care. So these are all sort of things that are still happening. And then we're still following up with folks in terms of post-hospitalization. We're still coordinating with other specialists and services, but we're not doing that. We're not billing that. So the dementia care, again, you would think would be exactly identical. I think the services that we're doing by and large are. Staffing's a little bit different. So one thing to think about with GUIDE is the idea is that you have a monthly payment, you have these required services or care elements you need to include, and then you're held to these outcomes. Beyond that, it's pretty flexible in terms of how you deliver the care, but there are requirements for your staffing. So that your practitioners need to be, I call them dementia proficient clinicians. Of course, there is the specialist training that we've offered, again, through support of the John A. Hartford Foundation and GAPNA, called the Dementia Care Specialist. So all of our nurse practitioners have completed that training. But there needs to be that dementia proficient clinician, or all of them in our case, meet that criteria. And then there's the dementia care navigator. And there's a little bit of people might staff that differently. For us, it is one of our registered nurses who fulfills the sort of official role of dementia care navigator. Not that she's the only one doing all the care navigation and coordination, but she's the one who makes sure. So there's been a little bit of a staffing where we've carved out time for one of our nurse practitioners to be the GUIDE manager and one to be the dementia care navigator.
Is there a training requirement that's specific for the care navigator?
Yes, we did have to identify what we had done for the training. And our registered nurses, again, I can't say enough about everyone on our team is amazing. And so we all just adore our registered nurses. And they were the first two in the country to complete a program called Dementia and Palliative Education for Nurses, or DPEN, which here at GSA 2024, we're in Seattle, and that was out of the University of Washington.
Oh, terrific.
Yeah, so they completed that training, and that was some online asynchronous didactic as well as synchronized meetings with faculty to review cases. But they'd also completed a few other pieces that we had put together locally, but I would say the bulk of what they did primarily for their training was that. There is a list of required content, but I wouldn't say there's one source today that you go to this one training.
I see.
I anticipate there will be a few of those coming. The only thing I would say in terms of our dementia care changes, you have to do comprehensive assessments, so cognition, behavioral function, done those for almost 10 years. Different measures, though, because there's some standardizations. We're having to make some switches to the clinical dementia rating scale, which is not something we've used before. And then there is a home safety check that we've figured out a way to incorporate. We have a significant number of our patients who reside in congregate living, assisted living, senior housing, and so forth. And so those people we do already do some home visits with potentially, but just staffing and the logistics, and also asking patients if they're okay with you coming to their home, which has gone okay for us so far because we have a relationship with people, but is not always an easy thing for beneficiaries to say, sure, come to my house. And then the last piece under caregiver services, we offer that in-house. I know other practices will be using different community agencies potentially, but we've done support groups, classes, and now we will be administering a respite program. So that's probably the biggest lift, I would say.
I think it's been really interesting to try to pitch Guide to our current existing patients, because we have said Guide is this new program that's being offered. You're eligible. We've screened our patients. We know which ones have traditional Medicare and live in the zip codes that we will be serving through the Guide program. And they're perplexed. They say, don't you already do this? And so it's been difficult for our families to say, sure, I'll agree to these extra things, because they're getting most of the comprehensive care. They've already been getting that within the Integrated Memory Care program. And so it has been a little bit perplexing for people. It does allow us to really have a stronger partnership with families, because instead it says, I am agreeing to be contacted by you regularly. I'm agreeing to talk to you. I'm agreeing to allow you to come into my home and do these things, do this safety check. So it is a stronger partnership, I think, or a more official partnership with our patients and families than we have had in the past. And we are a pretty high-touch clinic to begin with. So it's quite a privilege to be able to serve in this way. I do think the respite piece is what attracts a lot of our patients and families to this. And so that offering of additional in-home care, it's always difficult to try to have families who they think respite's going to be covered, they think the assisted living is going to be covered, and now we can say it might be. Here's some options for you, which is so nice as a social worker to not always have to be delivering the bad news.
Sure. You mentioned zip codes. Can you tell me, did you choose zip codes, or did CMS assign you zip codes? How do they align in your geographic area? What does it mean for the amount of folks you can serve?
So we mentioned zip codes. You do have to tell CMS where you will be serving, but they did not prescribe that for us. So with our respite partner, we thought it would be too big of a heavy lift to have Emory Healthcare or myself personally be partnering individually and directly with private duty caregiver agencies, adult day programs. We may still do that, but just it's with as large of an area as the Atlanta Metro is, as many of those organizations that are out there in the Atlanta area. We partnered with Jewish Family and Career Services in Atlanta. They have been running a voucher program very successfully with the Area Agency on Aging, with other programs in the Atlanta metro area. So they were a natural and obvious choice for us to reach out to. And the only reason we are restricted to zip codes is because these are the zip codes where they have partners already providing these services. So for us, we said we will serve patients. This is how you're going to do it. This is how we're going to implement this respite benefit. And we're only serving patients who are living within their territory.
I think it's important for people to know there's a lack of clarity about how the respite works, right? So the $2,500 is the cap that you have that we can spend on one person in a year. And it's not like a voucher or like a gift card, right? Where you can go get your home care agency and spend down the gift card. That's the total amount. But if you're doing in-home respite, which is the required respite to offer, that is in like a sort of a unit of 4-hour blocks. And there's a set rate that Medicare will cover for that 4-hour block. And there's a little bit of I'm glad we've been friendly partners and collaborators for a long time, because here's what I'd like for you to accept as payment. Because you cannot say, let's say the respite for 4 hours you have $125 covered, but the agency charges $160. You cannot balance bill the patient for that remaining $35. you are figuring out like how much of this, if it's going to be more than that, like, will this group accept the Medicare payment? If there are any fees beyond that, then your practice is going to have to cover that. And so the thought is like you're receiving this monthly payment that is, again, you have a lot of flexibility with how you manage it. And so it's entirely possible, I would say likely, if you're working with a partner or even if you're doing administration yourself, you're probably going to have expenses above and beyond what that costs. And so that's going to come out of the overall budget. And it is with the agencies that are under contract. So you don't get to shop, right? It's part of the program. That said, having some amount of covered respite, this is not going to cover you for a year. It's not going to cover you for 6 months. It's going to be like some number of days. I think 20 days is 20 units of that respite for our folks is about what we're estimating. But let's say your husband has surgery and he's taking care of his wife. That is exactly the time he's going to need some home respite. Or this sort of gets you through until some other thing is going on. It's still hugely valuable. The fact that we've never had coverage for respite before and now we have something it's a huge deal. But there's some logistics to work through.
I imagine. Thank you both for joining me here in the podcast booth in Seattle at GSA 2024. I'd like to ask you each to leave our listeners with one final thought.
GUIDE is an exciting program. I'm most distressed when people have never heard of it. Really glad to get the word out, but I think very exciting and a big move by Medicare to recognize that there are tremendous needs for people living with dementia and their caregivers, and an effort to try to address some of those through this test, and we sure hope it works.
And Laura, how about you? Final thought.
Yeah, I am so excited about GUIDE and the acknowledgement that good dementia care is more than a diagnosis. Good dementia care really is those wraparound services and support for the caregiver as well. And I am hopeful that this is going to make a huge impact on the many families who are living with dementia in America.
Again, Laura and Dr. Clevenger, many thanks for your time and insights today. It is always a pleasure to sit down with you ladies, but especially when we can do it in person at GSA 2024. So thanks so much for those listening to the podcast. I hope you found it enjoyable and informative. Thanks again, ladies.
Thank you.
Thank you.
Check out GSA Enrich at gsaenrich.juron.org, which is your gateway to a library of engaging learning resources. Access toolkits, courses, webinars, and more podcasts, all tailored to support your interest and advancement in the field of aging.